This lecture over Chapter 19 will cover nutrition and metabolism, and in this lecture we are going to talk about the metabolic function of the liver. We'll discuss the differences between macronutrients and micronutrients. We will also discuss the regulation of food intake, metabolic rates, eating disorders, and body temperature. Nutrition is a term that refers to the food that we eat and the nutrients they contain. Proper nutrition requires a balance of 3 basic types of energy-yielding nutrients, and those are referred to as carbohydrates, fats, and proteins. And then we have other essential components added in that we refer to as vitamins and minerals. So the process of metabolism is using these nutrients, and there's 2 ways that we do this. One, we break them down through the process of catabolism so that we can get energy to our cells, and the other way is through anabolism, which is the building of smaller molecules into bigger ones. So the liver has made appearances in several of our other lectures, so this is just a review about the various functions of the liver. Remember that the liver manufactures bile. It secretes it as well, but it is processed in the liver and it is stored in the gallbladder. It also helps to filter and detoxify our blood, right, via the hepatic portal circulation. It also assists with the maintenance of normal blood glucose concentration by removing excess glucose from the blood and turning it into glycogen and storing it there. It also helps us with the manufacture of the various proteins that help with the clotting process. Remember, like prothrombin and fibrinogen and other plasma proteins that assist with the clotting process. And then it also stores several other substances as well, such as iron and various vitamins like vitamin A and vitamin D. In a nutshell, the liver is amazing. Dietary sources of nutrition are broken down into 2 basic types or categories. And the first one is macronutrients. And macronutrients are our carbohydrates, our lipids, and our proteins. When we talk about carbohydrates, we're talking about sugars for the most part, like our monosaccharides, disaccharides, and polysaccharides. And our fats are going to consist of triglycerides that are absorbed as fatty acids or glycerols, so that is the end product of the chemical digestion or breakdown of fats or lipids. And then the last macronutrient on our list is proteins. And proteins come in many types, but basically they are these simple to complex chains of amino acids, and we can get those from like meat, eggs, dairy, vegetables, and so on. Then we have our micronutrients. Our micronutrients are our vitamins and minerals, and they're called micronutrients because we only need a really small quantity of them in our diet to be healthy. Here is a lovely mind map that I put together regarding the nutrients, and there are 2 major categories, macronutrients and micronutrients. And here you can see the macronutrients are divided into those carbs, proteins, and fats, and that carbohydrates are basically our sugars. They come from things in our diet like fruit, sugars, grains, vegetables, nuts, and so on. The proteins are either incomplete or complete proteins, and those can come from meats, eggs, dairy, vegetables, and nuts. And then fats, there's various types of fats, whether they're saturated or unsaturated, And again, these can come from meats, eggs, dairies, vegetables, and other types of oils. Then we have our micronutrients that are our vitamins, our minerals, and we have water hanging out over here. Two different types of vitamins, water-soluble and fat-soluble vitamins. Carbohydrates are the preferred energy nutrients of our bodies, and complex carbohydrates are broken down into smaller building blocks, which is primarily glucose. And our cells need glucose to be able to perform something called cellular respiration. Glucose catabolism, which we're going to talk about next, the breakdown of glucose right into usable energy, happens in 3 steps. The first step is glycolysis. The second step is the Krebs cycle, or we refer to it as the citric acid cycle. And then the third step is the electron transport system, which results in 36 amazing little power units called ATP, or adenosine triphosphate. So we're going to break down that process and talk about it in detail. Okay, so let's set the scene for this cellular respiration that we're going to talk about. In the liver, glucose is stored as glycogen. It's also stored in the muscles as glycogen. Glycogen can also be stored in the fat, but for the purpose of this, we're just going to say the liver. Okay, so glycogen is being stored in the liver, and the cells are needing glucose to make energy. So chemical communication is going to tell the liver to start a process called glycogenolysis. And this is going to break apart that larger glycogen molecule. That's called catabolism. So glycogen is going to be catabolized into glucose. Glucose is a 6-carbon chain molecule, and you see it here. And that is kind of where our story begins. Okay, so glucose has entered the scene in the cell, in the cytoplasm. Now, this process, glycolysis, takes place in the cytoplasm. It does not use oxygen, so it is an anaerobic process, and it yields 2 ATPs, 2 little bits of energy. But this is just enough energy to fuel the rest, to fuel these processes that are going on in the cytoplasm and get these pyruvic acids moving into the mitochondria, where the real work can take place. Okay, so glucose enters the cytoplasm as this 6-chain carbon molecule. Okay, so it's floating around in the cytoplasm, having a fun time. It traveled all the way from the liver after it was broken apart, and it's rejoicing because it's not going to require any of that oxygen to do its business. Okay, so what happens next? What happens is glucose is going to get broken again, all right? And it's going to get broken into 2 molecules of pyruvic acid. And you see them sitting down here at the bottom, 2 3-chain carbon molecules. We call those pyruvic acids. Okay, so glucose gets broken into 2 pyruvic acids, and then they need a little bit of assistance to move into the mitochondria. So there is a very helpful enzyme called coenzyme A, and it's kind of like the Uber ride for the pyruvic acid, all right? So they are going to get on their cell phones and get an Uber. No, coenzyme A is floating around in the cytoplasm, and it is going to join up with pyruvic acid. And when it does, the the pyruvic acid is going to lose one of its carbons, and it's going to join with the coenzyme A to make something called acetyl coenzyme A. And when that happens, it's each of these 3 carbon molecules are going to lose 1 carbon. And we're going to pick up that story on the next slide. Okay, so here we are. The Uber ride with the coenzyme A cost each of these molecules a carbon, and now we're using oxygen. Okay, we're in the mitochondria. We're getting ready to make some energy for our cells. This is the start of that citric acid cycle, step 2, if you will, okay, or the Krebs cycle. So this uses oxygen. It happens in the mitochondria. And so the acetyl CoA arrive into the mitochondria. They have 1 carbon less now. There's still 2 molecules, and we can see where carbon dioxide is starting to become a waste product of this process. Okay, so what happens next? What happens next is this acetyl CoA is going to get broken up again, all right? And when that happens, we have more oxygens that are going to be joining with those free carbons, right? So now we get 4 more molecules of carbon dioxide, okay? More waste product of the cellular respiration cycle. All right, so what happens next? This glucose molecule that we had that was 6 carbons, all of its carbons have been broken apart, and at each point, electrons are being released, right? So now we have all of these free electrons kind of floating around. And the last step, step 3 in our process, takes place with the electron transport system. Right, so the electron transport system is embedded in the inner folds of the mitochondria, and its job is to transfer energy from the electrons into molecules of ATP. And we're going to see a yield of 36 molecules of ATP. So how do they get to this electron transport system? Well, there's a molecule called NAD+. And we call it that for a reason, because if we say the whole thing together, it's nicotinamide adenine dinucleotide. All right, how do we get NAD+? NAD+ is a combination of vitamin B3 and some ATP. Now, sometimes we see it change into a NADH, and that's because not only does it pick up electrons, it can also pick up hydrogen. And this NAD+ is the transport molecule that is going to move those electrons to the electron transport system. And then our ATP, our 36 molecules of ATP will be yielded. Okay? This is, in a nutshell, the cellular respiration process. The energy transferred to ATP molecules differs in 2 major ways from the energy stored in nutrient molecules. And the first way is that energy in ATP molecules is not stored. It has to be used right away. So it's released almost instantaneously. So it's very fast. Right? These macro molecules that eventually yield energy have to be broken down and broken down and broken down until they can get to into glycolysis and the Krebs cycle so that they can be transferred, right, into ATP. And then ATP is also used to do the cellular work, right? So the release of the energy stored in nutrient molecules occurs much more slowly because of the catabolism of that nutrients must occur first, and then the ATP must be made before it can be used. Now, when ATP is used, what happens is ATP has 3 phosphates attached to an adenosine. And when one of those phosphates is broken off, energy is released, and it is turned into a 2-phosphate attached to an adenosine. So we get ADP, and then the process just regenerates the cycle over and over and over again to make those energy molecules. All right, so we've already discussed the breakdown of glycogen, and we said that that process of breaking down glycogen is catabolism, and the name of that is glycogenolysis. So now we're going to talk about the opposite, where we have smaller glucose molecules, and we're going to build them up into bigger molecules called glycogen that are going to be stored in the liver, the muscles, the fat, and this is called glycogenesis. So the condition of making new glycogens, right? Glycogenesis. This is chiefly carried out in the liver and the muscle cells, and sometimes we refer to glycogen as animal starch. Later, when it's needed, again, the liver and the muscles are going to break down those glycogen molecules into glucose molecules so that they can then enter the cytoplasm and be broken down through glycolysis in the Krebs cycle and then turned into ATP so they can be used for energy. So when we talk about blood sugar normally is about 800 to 110 milligrams per 100 mLs of blood when someone is fasting. And we've already talked about how the islets of Langerhans, they secrete insulin. And insulin is a hormone that helps move glucose out of the blood and into the cells so that it can be used for energy, right? But there are also some hormones that increase blood glucose. Insulin decreases blood glucose, but hormones that increase blood glucose are growth hormone, cortisone, epinephrine, and glucagon. And remember, glucagon is also secreted by the pancreas. All right, so if your body is anything like mine, it prefers carbohydrates over any other type of food that there is on the planet. All bodies are like this. Bodies prefer to use carbohydrates for energy because they're most closely related to the glucose molecules that the body needs to use, and it takes less energy to break down carbohydrates. So the body is going to break down carbohydrates first. It's going to choose that as its energy source before it chooses anything else. So let's say carbohydrates are off the plate, so to speak. The next favorite thing for the body to metabolize are fats. And fats are converted to glucose by catabolism, so they're broken down. The products of fat catabolism are fatty acids and glycerol, and extra ones get stored in the adipose tissue. Isn't that awesome? And then the last and least favorite energy source for your body is proteins, because it takes the most energy to break down these proteins, and then the body has to anabolize, right? Build from those amino acids glucose molecules. All right, so this requires something called gluconeogenesis. So that process will occur to convert those amino acids into glucose. So again, when we're talking about the catabolism of those macronutrients, the carbs, the fats, the proteins, carbs are most easily broken down into glucose. Fats are eventually catabolized into glycerol, and then they enter the Krebs cycle at that point. So they don't go through glycogenesis. They're going to skip that part that happens in the cytoplasm, and they're going to enter right into the Krebs cycle in the mitochondria as a product there. And then proteins are catabolized to their most basic components. Remember, amino acids are the most basic components of building blocks of proteins. And so the catabolism of proteins renders them back to amino acids. And that amine group is removed and excreted as a waste product in the urine called urea. All right. And then only about half, so the body has to have amino acids to be able to survive, and typically the body prefers to anabolize proteins or build them from smaller building blocks as opposed to catabolizing them to get us energy. So the way that it does that is by using amino acids that are already there in our body to build up those essential amino acids that we need to live. So there are essential amino acids that we can't live without, and then there are non-essential ones that we can live without. All right. They can be missing from the diet because they can actually be manufactured by us, but essential ones cannot, and so we have to get those in our diet. So why do we need vitamins anyways? Well, we need vitamins because vitamins attach to enzymes or coenzymes, and this process helps them to work properly, the enzymes to work properly. So if we don't have the necessary vitamins floating around in our bodies, then these enzymes that need to do jobs in our bodies aren't going to be able to do the jobs that they need to do to keep us healthy and alive. Now, there's two different types of vitamins. There's fat-soluble and water-soluble. And fat-soluble ones can be stored in the liver so that we can use them later. And examples of those are vitamins A, D, E, and K. And then the water-soluble ones like vitamin B and C, they can't be stored in our body, and so we have to get them from our diet. And if we don't, that's going to cause some sort of vitamin imbalance, and that can cause serious effects in our bodies. So a couple different terms to be familiar with. Avitaminosis is a deficiency of vitamins, and that can lead to some severe metabolic problems. And then avitaminosis of vitamin C, remember, can lead to scurvy, which is something that, a long time ago when we were spending a lot of time on ships and we didn't have vitamin C in our diet, then those individuals were prone to getting scurvy. And then the flip side of that is hypervitaminosis. That's when we have too much. Now, a lot of the excess vitamins that we take in can be excreted in the urine, but we can have too much of a good thing, of course. So if you take a peek at the chart in your book on page 540, you'll see a list of the major vitamins there. Vitamins are considered inorganic substances, and like I said, most of them help activate enzymes that have jobs to do in our bodies. So I just highlighted some of the most common ones here, like vitamin A. Vitamin A plays a role in detecting light in the sensory cells of the retina, so eat your carrots. Vitamin C helps manufacture collagen fibers. Eat your oranges. Vitamin D can be converted to a hormone that helps regulate calcium, homeostasis in the body. Get your sun. Vitamin E acts as an antioxidant that can help remove free radicals from the body that can eventually damage the DNA of our cells and the cell membranes of our cells. And then vitamin K is needed to produce certain clotting factors like we talked about in previous lectures. Now, while vitamins are organic substances, minerals are inorganic substances that are typically found naturally in our earth, in and on our earth, and they're required by the body for normal function similar to vitamins. They also assist enzymes and help them work more effectively. And we know from talking about the nervous system and the muscular system and the skeletal system that calcium is an important component of muscle function, bone health. Sodium and potassium help us to have a healthy immune system and to be able to carry out those processes of transferring nerve impulses from neuron to neuron. So where can we get calcium? We can get that from dairy and some different beans and vegetables. Again, it helps with clotting, formation of bone, nerve, and muscle function. If we don't have it, right, our bones aren't going to be strong and healthy, and our nerves and muscles aren't going to function correctly. Potassium, we can get that from dairy and meats. Again, it really helps with our muscle health and our nerve function. And if we don't have it, our heart could cease to beat altogether, right? And then sodium, we can get that from our diet as well, from salty foods, or we could add salt from the salt shaker to our foods. And it also aids in muscle and nerve function, also with fluid balance. And if we don't have sodium, again, our nerves aren't going to fire correctly, our muscles aren't going to work correctly because our nerves aren't firing correctly, and then that can lead to other issues as well. So how do we know when to eat or when to stop eating? Well, that is thanks to our hypothalamus. Our hypothalamus has two different areas that control appetite and promote feelings of hunger. And then there's another area called the satiety center that promotes feelings of being full or satisfied. Now, when we eat really fast, it takes a little bit of time for our gut to tell our hypothalamus that we are full and satisfied. So if we eat really quickly, which we get prone to do when we work in the operating room, and we have 30 minutes to get out, get food, and get scrubbed back into our case, we have a tendency to eat really quickly. And so because it does take some time for that communication, oftentimes we eat more than we should. All right, so there's a lot of factors that influence the feelings of hunger or being satiated, if you will, and that could be our good old emotions, right, or environmental cues. I don't know about you guys, but when I was growing up, we celebrated with food. And so that was just something that we did. And so it could be environmental cues, it could be cultural, right? It could also be more systemic within our bodies, right? It could be due to hormone fluctuations or various neurotransmitters that are released. It could also be due to habits, right? Habits that we have. My grandmother used to get furious at my grandfather because she would say, "Are you hungry?" And he would look at his watch, right? Because if it wasn't noon, then it wasn't lunchtime, whether he was hungry or not. All right, wait for it. I am about to demystify everything about dieting that you would ever want to know. So, two things. One, basal metabolic rate. Basal metabolic rate is the energy that your body needs to just be awake and alive and breathing, okay? Just that minimum amount of energy that you need to be alive, all right? And then your total metabolic rate is the total of the amount of energy that your body is going to use per day. So then we have our food intake, right? So if our calories that we're taking in are equal to our total metabolic rate, our weight is going to stay the same. So what happens if we eat more calories than our total metabolic rate? That's right, we're going to gain weight. And the reverse is true if we have less calories than our total metabolic rate, then the experts say that we will lose weight. So, all of these different fad diets and, different things, it's really very simple. If you take in less calories than you burn, then you're going to lose weight. So what are some characteristics that impact our basal metabolic rate and our total metabolic rate? When we're talking about our basal metabolic rate, we're talking about the size of our body, our age, hormone fluctuations, our body composition. Are we more muscle? Are we more fat? And then are we sick? Are we on different medications? And what are our cortisol levels? Different emotions can increase levels of cortisol, which can cause us to hold on to weight. And then we have our total metabolic rate, right? What are some influences there? Exercise. Exercise is going to increase that. Food intake is also going to impact that. Our environment that we live in and the temperature as well. When we talk about metabolic imbalances or metabolic disorders, we're either born with them or we acquire them later on due to other conditions that we may have. So inborn errors of metabolism, this is something that we inherit, and maybe we don't produce the enzymes that we need to produce that are relevant to metabolism. An example is phenylketonuria, and that is a decrease in the enzyme that breaks down phenylalanine. And if you've ever heard of a PKU stick, every baby that is born in the United States gets a PKU, and this will tell us if they have this abnormality. And it became the standard of care because there was a baby that died because they did not diagnose the baby with phenylketonuria. And now that is the standard of care. It's unfortunate that sometimes it happens that way. And then when we're talking about hormonal imbalances, this could be due to some sort of condition. Some examples would be hypothyroidism or hyperthyroidism. There are 3 types of eating disorders that the book talks about, and the first one, or 2 really, but the first one we're going to talk about is anorexia, and anorexia is the refusal to eat, not eating food. This can also be connected to some sort of underlying psychological or behavioral conditions. About 9 in 1,000 women and 3 in 1,000 men develop anorexia, and the average age is about 19 years of age for the appearance of anorexia. Bulimia is another one. Bulimia is when people eat and then they purge or they vomit. It affects about 15 in 1,000 women and 5 in 1,000 men, and the average age is about the same, right, as anorexia, 19, 20 years old. And then binging eating disorders is also talked about here in this image, where there are certain instances where there is binge eating, but there is not purging, and that seems to be a bit more common. Then lastly, there is obesity, which has become an epidemic in the United States for sure, And obesity can lead to many other comorbidities that can increase, the mortality rate of the individual, and can bring on other conditions like type 2 diabetes, various forms of cancer, gallbladder disease, heart disease, peripheral vascular disease. There's a whole myriad of other conditions that can be comorbidities that are associated with obesity. There are a variety of causes of protein-calorie malnutrition. The book categorizes them into 3 broad areas of conditions that reduce nutrient intake, conditions that increase loss of nutrients, and conditions that increase the use of nutrients in the body. Some that we may be directly impacted by in the operating room is hemorrhage, which is a condition that increases loss of nutrients. And then several conditions that increase the use of nutrients of the body, like burns, infection, trauma and surgery, and the presence of tumors. These protein-calorie malnutrition conditions, or PCMs, may be a complication of a pre-existing condition. There are 2 main types that the book talks about. One is marasmus, and the other is kwashiorkor. And marasmus is caused by an overall lack of calories and specifically protein, and it's characterized by tissue wasting and fluid and electrolyte imbalances. And then kwashiorkor is very similar, but focuses in on lack of protein. There's sufficient caloric intake, but the protein component is missing. And so this results in similar symptoms as marasmus, but we also see pronounced ascites. So we get that really like big belly syndrome, or really bloated belly, and then flaking dermatitis because the skin, because the cell walls are lacking the plasma proteins that they need to allow water to move in and out of the peritoneal spaces. We've had discussions before about the hypothalamus and how it assists in the regulation of body temperature and helps to maintain homeostasis through the process of thermoregulation. We've also talked about how this is a negative feedback loop and how blood flow to the skin increases when the body is overheated, so that moisture can escape and heat can escape. And heat is lost through the skin by 4 different means, and they are radiation, conduction, convection, and evaporation. So here we can see those 4 types of heat loss pathways. Radiation is the first one here, and it's the flow of heat away from the blood and the skin. The second one is conduction, which is the transfer of heat to the skin and then to a cooler external environment. This is similar to, let's say you have a cold glass of ice water and you're holding on to it. Over time, your skin is going to feel colder, right? And then if you hold on to it for a long enough time, both will stabilize to an equal temperature. The next one is convection. If you think of a convection oven, this is the transfer of heat to cooler air that is flowing in and around the skin. And then the last one is evaporation, which is absorption of heat from blood and skin by water, or sweat vaporization. And so this is a big deal in the operating room. Remember how we talked about the environment of the operating room is really cold. It's 65 to 75 degrees. And when you're in there and you're in a little flimsy gown and you don't have any other clothes on besides that, it is cold. And then when we get ready to do surgery, we're going to uncover all the area that we're working on. So the more area of the patient's body that's exposed, the more at risk they are for losing heat and eventually developing hypothermia. So these four pathways of heat loss also occur in the operating room as well. We have air circulating, right? Laminar airflow, we talked about that. And so air is consistently circulating. That 65 to 75 degree air is, pulling heat away from the body. Also, the patient is laying on a relatively cold operating room table. That's going to allow heat to be lost through conduction. And then radiation as well, right? Just from your body being in an environment that's colder than the actual temperature of your body is going to cause us to lose heat. So some things that we do, we have blanket warmers. And when the patient comes in, we make sure we cover them with warm blankets. We only keep the areas uncovered during surgery that need to be worked on, and we expedite that surgical procedure so that they're not exposed to the environment of the OR any longer than they have to be. We can also use other special warming devices like a bear hugger. And a bear hugger is basically a vacuum in reverse, and it blows hot air or warm air through a hose, and we can connect that to a disposable type blanket that either covers the top arms and chest of the patient or the lower body of the patient, and we can help keep them warm that way. So there's a variety of things that we can do, but this underscores how important it is for us to know our job, expedite our role so that the surgery is more efficient and there's a shorter duration of surgical time so that the patient is exposed to that environment for the shortest amount of time as possible. Two types of abnormal body temperature that we're going to talk about is fever and malignant hyperthermia. Fever is actually caused by an infection, typically in the body, and it is a reset of our hypothalamus to a higher temperature. This is going to facilitate the response of our immune cells to that area where there is an infection or something going on. And then malignant hyperthermia is typically an inherited condition, and this causes a drastic increase in body temperature and muscle rigidity. And this is an occurrence that we may have to deal with in the operating room because there are certain anesthetics that the anesthesia care provider will give that can trigger malignant hyperthermia, or MH, we sometimes refer to it as. And so the first thing that the anesthesia care provider is going to notice is that the patient's end tidal carbon dioxide, CO2, is going to rise. And so the first thing that they're going to do is stop administering those anesthetics that could possibly be triggering the malignant hyperthermia. They're going to increase oxygen saturation to 100%. And then we're going to administer a medication called dantrolene that counteracts the condition of malignant hyperthermia and what's going on in the body. And typically what they'll also do is pack the groin and the axilla and probably up around the neck with ice packs to help cool the patient down. If for some reason this happens intraoperatively and not during induction, then we can also irrigate. If we're in the abdomen, let's say, working in the abdomen, we can irrigate the abdomen with some cooler fluids or saline solution. Anesthesia care provider can also do an ice lavage through a nasogastric tube down into the stomach, lavage the insides of the body with some cold fluids and hopefully bring this temperature down. I've experienced MH once in the operating room. It was supposed to be an appendectomy on this young man. He was about 13 or 14 years old, I guess, and the symptoms occurred during induction. So we were able to postpone the surgery until the next day. The appendix wasn't acute enough for it to be a dire emergency, so we put it off for a day, brought him back, did the procedure with no complications. The anesthesia care provider avoided using those anesthetics that would trigger some sort of malignant hyperthermia. So an important question that the anesthesia care provider is always going to ask is, does the patient have a history of MH, or does anybody that they know in their family have a history of MH? And that can clue us in to be prepared for a certain situation. And typically in the operating room, there is an MH cart that has the medications and all of those things that we would need if there were to be a malignant hyperthermia crisis. So two other situations common in Arizona actually, right, because it's pretty warm here, are heat exhaustion and heat stroke. Heat exhaustion is a results from the loss of fluid as the body tries to cool itself. So remember, evaporation and sweating, and we're losing water and electrolytes as we try to cool ourselves in that situation. Some symptoms could be feeling faint or dizzy, headache, profuse sweating, rapid and weak pulse, shallow breathing, pale, cool, clammy skin, nausea, vomiting, and muscle cramps. And then the treatment is to just get that individual to a cool place and have them drink some water if they are able to. If not, then an IV would probably be the next step in that process. And then heat stroke, we also refer to that as sunstroke. It's overheating of the body resulting from failure of that hypothalamus to regulate the temperature in a warm environment. So we're not really going to see a lot of sweating, but we're still going to have the headache. The patient's face and skin may look red or feel hot to the touch. The temperature could be 103 degrees plus. It could be accompanied by nausea or vomiting, a strong rapid pulse, confusion, convulsions, and eventually they may lose consciousness. In this type of situation, we want to make sure we get the patient to treatment as soon as possible. So call 911, try to cool that patient down, maybe wrap them in some wet towels or maybe a wet washcloth and kind of wipe their forehead, try to get them cooled down. And lastly, hypothermia and frostbite are the opposite end of the spectrum that we've been talking about. So this is a body temperature that's too low. Hypothermia results from failure of the hypothalamus to regulate the body temperature in a cold environment. And prolonged exposure to a cold environment can lead to frostbite. And this is death of the tissue because of the extremely cold environment. Typically, it starts at the fingertips and the toes, so the very far extremities, because when the body is cold, it's going to experience vasoconstriction, and that's going to hold the blood and the warmth closer to the core of the body. And so the extremities are going to be missing out on the warmth of that blood flowing like it typically would. And so like we talked about in the operating room, it's a very cold environment, and we do several things to keep our patients warm. Like I said, we want to make sure that we keep them covered, expedite the surgery so they're not exposed to the environment any longer than they have to be, use those bear hugger devices, use warm blankets, and then the last thing is we want to use warm fluids when we're irrigating the wound. That's another important part of that as well. All right, so that brings us to the end of our discussion on nutrition and metabolism. I hope that you found this lecture helpful, and I look forward to discussing any questions that you might have in our upcoming class.